1, 2,
and female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep your heart again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is also dropping.
45 minutes of CPR and no return of circulation. Okay.
Alright guys, so this right here is going to be over dysrhythmia, arrhythmias. I don't know the difference between a dysrhythmia or an arrhythmia. If there is a difference, please, let me know. Or, for me, it doesn't really matter. I use the terms interchangeably. But what I will say is I do not know what arrhythmias they're going to go over in this particular episode because I haven't listened to it yet. But we can just kind of do like a little overview real quick. So your easy ones are going to be VFib, just look like a bunch of squiggles on the EKG paper or on the lead strip. And then you have fine VFib. Fine VFib, if you're taking like an AHA course, it will literally look like asystole, but they'll have a little bit of like a little wave in there, and they're going to be like, oh, that's coarse, or that's fine VFib. And you're like, that's asystole, but they're going to call it, fine VFib. And for the AHA is concerned, asystole is just quite literally a flat line. But in an emergency situation, fine VFib and asystole are going to look the same. But you have VFib, which is, like I said, it's going to be just that squiggle line on the EKG paper. And then you have fine VFib. It's just going to be smaller squiggles on the EKG paper. And then you have your VTAC, which is just going to look like big tombstones or the McDonald's sign over and over again. And then you have torsades, which you will get, the really, really big VTAC. And then it shrinks down into small VTAC or VFib. And then it shoots back out to VTAC again, and then VFib, and then VTAC. At least that's the way it looks on the EKG paper. Again, I'm not a cardiologist by any means, so I don't know what the hell is actually happening in torsades. All I know is that you're going to try to slow that shit down with some MAG and then hope for the best with your other ACLS drugs. And then you will have your AFib with RVR. Now, the big thing with AFib with RVR is that you're going to have AFib, and then in a run of RVR, you're going to have a very rapid, QRS complex, that are really, really close together. And then you'll get your rhythm back, of your AFib, which is that irregular, regular, kind of pattern. And then your RVR again will be like a really short, squished together QRS complex next to each other, maybe 3, 4, 5 of them. And then it shoots back out to your normal rhythm. And then you have a flutter. Now, not too long ago in the ER, I heard the term a flutter with RVR. I don't know if that's a thing. But if it is, then you're going to be looking for the same thing. You're going to be looking for your sawtooth pattern in between your QRS complexes. And then I'm assuming your QRS complexes are going to squish together. And you're going to get like 4, 5, 6 beats. And then it'll shoot back out to your normal rhythm. And then shoot back down into those really tight QRS complexes. And then I guess shoot back out to like the regular, irregular rhythm. And then that's your A flutter. And you have your NSR, which is your normal sinus. And then you have Brady, and then you have your tachy. And then I don't know if they're going to get into heart blocks in this particular episode. But the easiest way to tell a heart block is your heart blocks are going to be predicated by your P wave. And everything with heart blocks is going to be P wave related. So your first degree heart block, you're going to be having your P wave, which is going to be a little bit further away from your QRS complex than you would like it to be. I can't remember the exact numbers because I don't have an EKG ruler in front of me or the criteria, but your P wave will be completely, kind of move back a little bit. And that right there would be your first degree. Your second degree type 1, if I'm not mistaken, is your Mobitz 1. If I'm not mistaken, I should probably look this up before I give you guys the wrong information. Let me pause real quick. Okay, just checked it. So Mobitz 1 is your Winkenbach, arrhythmia, right? Heart block. And so it is the arrhythmia that has that little rhyme to it. Wider drop. Then you have a Winkenbach. Again, you're looking at your P wave. All these heart blocks, my little piece of advice to you guys, don't overcomplicate this shit. It's literally your P wave for these heart blocks. So with type 1 or with your first degree heart block, your P wave is sitting a little bit further back from the QRS complex, right? In your Mobitz 1, your second degree heart block type 1 is your P wave will be normal, and then it'll get further away from the QRS complex and then further away from the complex again. And then you'll have a drop beat, and then your P wave will show back up right next to your QRS complex and then start getting wider and wider out from the QRS complex before another beat drops. Okay, that's your type 1 for Mobitz. And then your type 2 is your P wave will stay the same. Whether it's further or closer to your QRS complex is irrelevant, but it'll be stationary. And then on your EKG paper, you'll just have a drop beat just out of nowhere, right? And then you'll get your beat back, and then the P wave will be right where it needs to be, okay? And then your third degree heart block is going to be your P wave is doing its own damn thing, right? So the atria are just doing their own thing. They're not synchronized with their ventricles at all. So they're contracting without any coordination with the ventricles, right? And so your P wave will be where it's supposed to be. It'll be like in this random ass spot between your T wave and your QRS complex, or hell, it could be hidden in the T wave. And what it will look like is that you'll have this little notch up or this little spike in your T wave, and then you'll have your QRS complex, or hell, your P wave could be hidden in the QRS complex, which is very difficult to kind of see on the EKG paper. You might get lucky and see a notch, in your, your R wave. You might get a little higher of a notch than everywhere else, or it might look like a bundle branch block. So you might get like a little cat ear looking thing, or maybe even a W in your, QRS, I guess your Q wave, whichever one is the bottom one that comes down. Damn it, it comes down, right? You might get a W with that, right? And so you might get fortunate enough to get that, right? But typically your P wave is going to be doing its own fucking thing, right? And it's not going to follow any sort of logic. It's just going to be doing its own thing, And so that's how you know that you're in a third degree heart block, which is your more serious heart block. I will say the rarest ones that I've seen is a type 1, your Winkenbach, right? Where it just gets wider and wider and then drops, right? I've only seen it once in clinical practice. And me and the hospitalist were like, what? Is that a type 1? And we were all excited. And the patient had no idea what the hell we were talking about because it's so uncommon to find. But so with your heart blocks, don't overcomplicate the shit. It is all going to be determined on your P wave. Okay? Again, your P wave is going to determine what type of heart block you have. All right? So don't be looking at your QRS complex. Don't be looking at your fucking T wave. Everything about heart blocks is going to be in your P wave, as in papa, your P wave. Okay? And then, again, I don't know if they're going to be getting into these, but you have your bundle branch blocks. So, again, I don't know, like lead 1, 2, 3, your V1, V2, V3, in your AVR, and I think it's SVR. Like, I don't know where you're going to find these at. Like, I know that, nurse practitioners and stuff like that, they can look, and your PAs and your MDs will look at the strip and they'll like compare lead 1 and 2 to like AVR or something like that. But for our intensive purposes for RN school, is your left and right bundle branch blocks. If I'm not mistaken, I believe, let me check before I give you guys wrong information. So with your left bundle branch block, your EKG paper might show like a little Batman looking thing where your QRS complex looks like either a cat or a Batman, where there's like 2 peaks, at the top of the QRS complex. It'll have like 2 peaks. Or your QRS complex on the part that goes down will look like a W. Okay. And then on your right bundle branch block, like when you're getting ready to repolarize, go for the ventricles to repolarize to get your T wave, that little space at the end of the QRS complex before you get to the T wave will look like a U. Like it'll dip down and make like a U, or you might even get an inverted T wave, right? And then they might go over, potassium, your peak T waves. Just remember, as the more and more potassium the body has, it'll start really throwing off the heart's ability to regulate itself. And so you can get these massive peak T waves to the point to where the QRS complex completely fades away as the potassium gets higher, to where the potassium gets so high that the only thing you're going to look at is a T wave. And at that point, you're just going to be running into VTAC if they sneeze, right? So it doesn't take much for them to get thrown into VTAC if they have that much potassium. So you're going to be looking at like insulin with dextrose, your DI, and then you're going to be looking at calcium, especially in high potassium. You're going to be giving calcium gluconate. The way I describe it to my patients who have high potassium is that calcium is going to go in and kind of hug the heart, because the heart's kind of having like this anxiety attack right now. And so calcium will go in and kind of give the heart a hug and keep it stable and keep it from throwing itself into this wonky ass arrhythmia, right? So it goes in and it hugs the heart, and then you have K-exolate, right? So you can shit it out. And then a new one is going to be albuterol. So there we give a lot of albuterol, which also helps the shift. So it's called a shifting protocol. In the ER, we call it a shifting protocol. So you're looking at D50. You might give an amp or two at D50 and then start an insulin drip to get the potassium back into the cells. And then you're going to be giving calcium gluconate. You're going to be giving K-exolate or Lokelma, whichever one that you have on hand. And then if they're really, really bad off, they might get hemodialysis, emergent dialysis to pull that extra potassium out. And then you have your arrhythmias with calcium and stuff like that, okay? But the big ones are going to be like potassium. And we went over VTAC, VFib. We went over the bundle branch blocks. And then we went over your heart blocks. And then we went over your atrial dysrhythmias with A-flutter and AFib, and then your AFib with RVR and AFib, or A-flutter with RVR, which is something new to me. So outside of that, man, I think that's it. All right. This is going to be the episode over dysrhythmias. I just wanted to make sure that we covered those because I don't know what they're going to touch on in this episode, but I want to make sure that, especially for the heart blocks, that you guys don't get tripped up with the heart blocks. Again, broken record. You're looking at your fucking P wave, all right? Your P wave will determine what type of heart block you are in. If your P wave is sitting a little bit further from the QRS complex, you're in a heart block type. You're in a heart block 1, first degree heart block. And then if your P wave starts marching away from your QRS complex, and then you get a drop beat, that's going to be a Winky block. Or Mobitz type 1, second degree heart block, Mobitz type 1. And then if your P wave is stationary, and then you get a random drop beat, that's going to be a second degree heart block, Mobitz type 2. And then if your P wave is just all over the damn place, your atria are just contracting whenever the fuck they feel like it, then you're going to be in a third degree heart block. Okay, so again, your heart blocks are going to be determined by the P wave. This is coming from nursing school. This is not a cardiologist telling you this, but for your intensive testing purposes, okay, your heart blocks are going to be determined by your P wave. Now, if you want to be a cardiologist and you want to say, well, your V1 and your V2 and your AVR, leads need to look like this and all that, well, then you do that, man. But in the ER and for nursing on our end, when just looking at the shit, your P wave determines what type of heart block you have. All right. And then, yeah, that's it. All right, guys. Enjoy the episode. Okay, I'm back like a bad habit. I want to go over PVCs and then bigeminy and trigeminy. Again, I do not know what arrhythmias this episode will go over because I haven't listened to it yet. But your PVCs are your preventricular contractions. So you will have like a normal QRS complex, right? And then just out of nowhere, you'll get this really bizarre looking kind of beat looking thing. And it's just where the ventricles just kind of contracted a little too early. So what I've come to learn is the ventricles are extremely sensitive. And so if the ventricles start reading that they're not getting enough oxygen, then they'll start to freak out. And then they'll start throwing PVCs like all over the damn place, right? So for a good chunk, I'm not going to give a percentage, but I will say if your patient doesn't have a cardiac history and you're in the ER, wherever the hell you're at, if they don't have a cardiac history, then if you see PVCs, they're probably just sitting in a weird position and you might want to just sit them up, pull them up, put some oxygen on them, something to get them to get oxygenated, even though their pulse ox is probably reading 90 or something like that. Just slap some O2 on them at 2 liters and then see if that kind of resolves their weird looking PVCs. Because again, the ventricles are extremely sensitive. We had a patient that had a shunt that the terminating portion of it dipped a little too low into the heart, and then I guess it started, rubbing the ventricles as it was contracting, and so it would throw a little weird PVCs whenever she would sit in like a weird position. And she said it was normal and she can feel it, so she sits in certain positions. That way it doesn't do that. But we'll go into bigeminy. And let me check before I give you guys wrong information. Okay. So bigeminy will be a normal QRS complex, and then you'll have a PVC, and then it'll be 1 for 1. So you'll have a QRS, and then you have a PVC, then you have a QRS, and then you have a PVC, you have a QRS, and then you have a PVC. That right there is going to be bigeminy. Okay. And then you have trigeminy, which is a 2-for-1 special. So you'll get 2 QRS complexes and then you'll get 1 PVC. So QRS, QRS, PVC, QRS, QRS, PVC, QRS, QRS, PVC. That will be trigeminy. Okay. So you'll just have your normal PVCs, and then you will have your bigeminy, which will be 1-for-1. So QRS, PVC, and then you'll have your trigeminy, which will be QRS, QRS, PVC. So a 2-for-1 special with trigeminy. So basically every second beat will be bigeminy, and then every third beat will be trigeminy. Okay. And now I think I am done.
When you look at a healthy city from above at night, it's like a perfect network of light. Everything is synchronized. Traffic lights change precisely when they need to, power routes to the neighborhoods pulling the most current, and the whole grid just hums.
Right, yeah, it's totally balanced.
Exactly. But if a main substation blows, or like a rogue signal scrambles the system, the entire city goes dark in an instant.
And that sudden darkness, that catastrophic failure of the grid, is exactly what we're looking at today, but inside the human chest.
Because we aren't just here to memorize squiggly lines on an ECG paper. Today, we are taking a really dense clinical text on electrocardiographic monitoring and aggressively applying an intensivist filter for this deep dive.
Yeah, we really are.
If you are an ICU nurse standing at the bedside, your job isn't to react to the darkness. Your job is to anticipate the deterioration before the grid goes down.
Exactly. I mean, critical care is about evaluating failing physiology in real time. You are constantly running this loop, like, what is the mechanical problem? How is the physiology failing? What is the immediate threat to the patient's life?
Right. And then, what is my intervention?
Spot on. And finally, the reassessment. So today, we are analyzing the highest yield, most dangerous cardiac dysrhythmias. We're breaking down exactly what will kill your patient first and the priority actions you have to take to stop it.
We've got to start with the absolute worst-case scenarios, like when the heart's grid just experiences a massive explosive system failure. We're talking about ventricular tachycardia, or VT, and ventricular fibrillation, VF.
These are the lethal threats. I mean, to give you the 80-20 breakdown, VT occurs when an ectopic focus, like a rogue cell in the ventricles, just completely hijacks the electrical system.
It takes over.
Yeah, it becomes the new pacemaker, firing at a massive rate, usually between 150 to 250 beats per minute, and then VF is the progression of that chaos.
So it gets worse.
Oh, much worse. Instead of one rogue cell, you have multiple ectopic foci firing all at once. The ventricles aren't even pumping anymore. They're just kind of quivering like a bag of worms.
So mechanically, like at the bedside, how does that actually translate to the patient's physiology? I mean, if the heart is beating at 250 beats a minute, isn't it just pumping a ton of blood?
That's a super common misconception, actually, but it's the exact opposite. At that extreme rate, your diastolic filling time is functionally 0.
Oh, wow.
Right. The heart is beating so fast that it never has a fraction of a second to relax and fill with blood. So if you have no filling time, your stroke volume basically plummets to 0. And if your stroke volume is 0, your cardiac output is 0.
Which means cardiopulmonary arrest, like 0 oxygen delivery to the tissues. The brain and organs are actively dying.
Precisely. The moment cardiac output drops to 0, you see this rapid clinical deterioration. Your patient becomes totally unresponsive, pulseless, and apneic.
And what are we seeing on the monitor?
On the ECG, VT looks like wide, distorted QRS complexes, so greater than 0.12 seconds, marching out rapidly with absolutely no visible P waves. VF, on the other hand, just looks like chaotic, irregular waveforms of varying amplitude. There is no structure to it at all.
Okay, but how do we spot the spark before the explosion? The source material talks a lot about this trigger called the R-on-T phenomenon. It sounds like something hitting at the exact wrong microsecond.
It is. So think of the T wave as the relative refractory period of ventricular repolarization.
The reset phase.
Exactly. The heart cells are resetting, and during that specific phase, they are incredibly unstable and highly excitable. If a premature ventricular contraction, a PVC, happens to fire and land perfectly on the peak of that T wave.
It's like slamming a car into reverse while you're speeding 80 miles an hour down the highway. Just completely shred the engine.
That is exactly what happens electrically. That single mistimed PVC throws the entire ventricular conduction system into lethal VT or VF.
So if I'm at the bedside and I see this wide, bizarre complex on the monitor, my instinct is to immediately grab the defibrillator and shock them.
Right. Stop right there. That instinct is like the #1 trap that novice nurses fall into on exams and at the bedside.
Wait, really?
Yes. You always treat the patient, not the monitor. Your absolute first priority nursing action is to check the patient's responsiveness and check for a central pulse.
But if the monitor shows VT, wouldn't they automatically be pulseless?
Not always. A patient can have stable ventricular tachycardia. They might be sitting up talking to you with a palpable pulse, even though the monitor shows VT.
Oh.
Yeah, and if you take the defibrillator and deliver an unsynchronized shock to a stable patient with a pulse, you could actually cause the R-on-T phenomenon we just talked about and literally push them right into lethal ventricular fibrillation.
Wow. Okay, so that completely changes the ADPIE protocol. If they are stable and talking, we're looking at synchronized cardioversion or IV antiarrhythmics. But if I check that pulse and there's nothing, like they're unresponsive and apneic, then what's the escalation?
Then you escalate instantly. Call the code. Next, you start high-quality CPR to mechanically force blood to the brain. Then you perform rapid defibrillation within 2 minutes.
And defibrillation is just a massive wave of electricity, like 360 joules for monophasic monitors or 120 to 200 for biphasic. But what is that electricity actually doing? Are we restarting the heart?
We aren't restarting it, no. We are momentarily stopping it.
Stopping it.
Yeah. The shock depolarizes the entire myocardium all at once. It wipes the slate clean. It stops all those chaotic ectopic foci in their tracks, with the hope that the sinus node, the natural pacemaker, can wake up, reboot, and regain control of the grid.
So while we are doing CPR and shocking, what are the primary meds we are pushing to fix the underlying physiology?
We use epinephrine first. It's a potent alpha-adrenergic agonist.
So a vasopressor.
Exactly. We aren't giving it to stimulate the heart. We are giving it to clamp down the peripheral blood vessels, skyrocketing the systemic vascular resistance so that whatever little blood we are moving with CPR gets shunted directly to the central circulation, the heart and the brain.
That makes total sense. And the source material mentions amiodarone as well.
Yes, amiodarone is our primary antiarrhythmic here. It's a class 3 potassium channel blocker.
And what's the mechanism there?
It works by delaying repolarization and prolonging the action potential. Essentially, it calms down that highly irritable ventricular tissue, making it harder for those rogue ectopic cells to fire again once we shock the patient out of the rhythm.
Okay, so if I'm synthesizing this into a core intensivist framework, and if you only remember 5 things about this. 1, the core pathophysiology is the ventricles going rogue, destroying filling time and cardiac output.
Yep.
2, the key assessment finding is an unresponsive, pulseless apneic patient. 3, the most dangerous complication is sudden cardiac death. 4, priority nursing action is immediate CPR and rapid defibrillation. And 5, the most important treatment is shocking the heart to reset the SA node.
You nailed it. So for the one-sentence clinical picture, it's a totally unresponsive patient with a chaotic or wide complex rhythm on the monitor.
Got it.
And if you see wide, bizarre QRS complexes and no pulse, think pulseless VT or VF and do immediate CPR and defibrillation.
Perfect. So that's what happens when the ventricles basically explode. But let's shift to a completely different kind of grid failure. What happens when the main power lines just get entirely severed?
You're talking about complete heart block or third-degree AV block. If VT is an electrical explosion, this is a silent choke.
The text describes this as complete AV dissociation.
Yeah.
So the top of the heart and the bottom of the heart are entirely divorced from one another.
Completely divorced, it's usually triggered by severe ischemic heart disease, like an acute MI or drug toxicity from beta blockers or digoxin.
So the physiology changes how?
Well, the SA node up in the atria is firing perfectly fine, generating normal P waves at 60 to 100 beats per minute. But the AV node, which is the gateway to the ventricles, becomes a brick wall. Absolutely no electrical impulses get through.
Wait, if no impulses get through, how does the patient not just instantly flatline and die?
Because the heart has backup generators, when the ventricles realize they aren't getting the signal, an escape pacemaker somewhere in the ventricular tissue wakes up and takes over.
Oh, that's a clever compensation.
It is, but here's the decompensation problem. The further down the conduction system you go, the slower the inherent rate. That ventricular escape rhythm only fires at 20 to 60 beats per minute.
20 to 60. So we're looking at profound bradycardia. The cardiac output must be tanking.
Exactly. The patient is bradycardic, hypotensive, and severely hypoperfusing. Early on, they might just complain of extreme fatigue, but you know they are actively deteriorating if their mentation drops, their MAP plummets, or they experience syncope.
On the ECG, how do we distinguish this from other blocks? I mean, I know there are second-degree blocks where beats get dropped.
Pattern recognition is key here. In second-degree type 1, or Benkebuck, the PR interval gets progressively longer until a beat drops.
Longer, longer, longer drop.
Right. In type 2, the PR interval is constant, but you randomly drop QRS complexes. But in third degree, there is zero relationship. The P waves march out at their own regular rate. The QRS complexes march out at their own, much slower, regular rate. The PR intervals are completely chaotic because the atria and ventricles are total divorced.
All right, so I've identified it on the monitor, and the patient is like gray, confused, and their blood pressure is crashing.
Right.
What is the priority nursing action? I know atropine is the standard ACLS drug for symptomatic bradycardia. Do we just push atropine to speed up the heart?
No, and this is a massive exam trap and a crucial bedside pearl. Think about the pathophysiology.
Okay, why not?
Atropine works by blocking vagal stimulation, which speeds up the SA node in the atria. But in third-degree block, the pathway is physically severed at the AV node.
Oh, so if you push atropine, you are just making the top of the heart beat faster. But that signal is still hitting a brick wall.
Exactly. It's like standing on one side of a canyon where the bridge is out and screaming at a stopped train on the other side to move. It does absolutely nothing for the ventricles. Atropine is useless here.
So we have to pace them mechanically instead.
Right. First priority. Apply transcutaneous pacemaker pads, TCP, to the anterior and posterior chest. Next, you set the pacing rate and the voltage on the external generator. Your goal is to achieve ventricular capture.
Capture meaning the electricity from the pads is actually successfully triggering the heart muscle to squeeze.
Yes. On the monitor, you will see a sharp pacemaker spike immediately followed by a wide QRS complex. And mechanically, you must confirm capture by feeling for a corresponding mechanical pulse.
But wait, transcutaneous pacing means we are shooting enough external electrical current through the skin, fat, and skeletal muscle of the chest wall to force the heart to beat. That has to be brutally painful for the patient.
Oh, it is agonizing. The current causes the chest muscles to twitch forcefully with every single beat. So an independent and vital nursing action, assuming the patient is conscious and has an airway, is providing immediate analgesia and sedation.
And TCP is just a temporary bridge, right?
Yes, exactly. While you are pacing them externally, you might hang a dopamine or epinephrine drip to temporarily support the blood pressure, but the definitive treatment, the THIDAN in your priority list, is preparing the patient for the insertion of a temporary transvenous or a permanent pacemaker.
Okay, pulling this all together for the 5 things to remember. 1, core pathophysiology is complete failure of AV conduction, so atria and ventricles beat independently.
Yep.
2, key assessment is profound bradycardia with signs of hypoperfusion, like shock or syncope. 3, most dangerous complication is periods of asystole and cardiovascular collapse.
Spot on.
4, priority nursing action is initiating transcutaneous pacing. And 5, the most important treatment is permanent pacemaker insertion.
Perfect. So the one-sentence clinical picture here. A patient with profound symptomatic bradycardia where the ECG shows regular P waves and regular QRS complexes that march out completely independently of one another.
And the rule of thumb.
If you see totally dissociated P waves and QRS complexes with hypotension, think complete heart block and do transcutaneous pacing immediately.
That is exactly how an intensivist approaches it. Now, we've covered the bottom of the heart going rogue and the connections being severed. Let's move above the ventricles to our final topic, the reat race. We are looking at atrial fibrillation and paroxysmal supraventricular tachycardia, or PSVT.
Right, these are supraventricular, meaning the chaotic electrical activity originates above the bundle of His.
But if the problem is in the top of the heart, why is it so dangerous for the whole system?
It all comes back to how the atrial behavior impacts the ventricles and ultimately cardiac output. Let's look at PSVT first. This is usually caused by a reentrant loop-like a short circuit that traps the electrical signal in a continuous rapid circle.
And what's the rate?
It causes abrupt, extreme heart rates of 150 to 220 beats per minute.
So we are back to the diastolic filling problem. Even though the signal originates in the atria, a rate of 200 beats a minute drastically cuts into the ventricular relaxation time. Stroke volume drops, causing profound hypotension and ischemia.
Exactly. But atrial fibrillation presents a different mechanical problem. In AFib, there are ectopic foci all over the atria firing chaotically, usually between 350 to 600 times a minute.
600. How do the ventricles not just match that rate and literally explode?
Thankfully, the AV node acts as a gatekeeper. It won't let all 600 impulses through. But because the atria are firing so chaotically, they aren't actually contracting. They are just quivering.
So they lose their squeeze.
Right. When you lose that synchronized atrial contraction, you lose what we call the atrial kick, that final coordinated squeeze of blood down into the ventricles right before they pump.
And how much does that actually matter for the patient's perfusion?
Losing the atrial kick drops your overall cardiac output by 20 to 30%.
Wow.
Yeah, if your patient already has a compromised heart, that sudden drop in perfusion can throw them right into heart failure.
So on the monitor, what's the distinguishing pattern between the two?
Well, PSVT is a regular, rapid, narrow, complex tachycardia. It's so fast that the P wave is usually buried inside the preceding T wave.
And AFib.
AFib is classically described as an irregularly irregular rhythm. The QRS complexes are narrow, but the distance between them is completely random. And there are no distinct P waves at all, just a chaotic fibrillatory baseline.
Okay, let's talk interventions, because I know they differ drastically.
Yeah.
Let's start with AFib. If the AV node is letting too many beats through, say, a ventricular rate of 130, our priority is rate control, right? We need to slow down that AV node conduction.
Yes. We use medications like diltiazem, which is a calcium channel blocker, or metoprolol, a beta blocker. But AFib has a unique, massive complication that you must assess for before you try to convert them back to a normal sinus rhythm.
The clot risk. Because the atria are just quivering, the blood isn't being efficiently emptied. It gets stagnant, especially in that small anatomical pouch called the left atrial appendage.
Exactly. Blood stasis leads to thrombi. If a patient has been in AFib for more than 48 hours, you have to assume they have a clot in their heart. If you just shock them or give them a rhythm-converting drug and the atria suddenly give a strong, effective squeeze,
you'll dislodge the clot, pump it right up the carotids, and cause a massive embolic stroke.
Precisely. So the nursing priority completely changes. If it's been over 48 hours, they require anticoagulation like warfarin or Eliquis for 3 to 4 weeks before you can safely attempt cardioversion.
Oh, 3 to 4 weeks.
Yeah. The only exception is if you do a transesophageal echocardiogram right then and there to definitively prove there is no clot.
That is a brilliant safety check to keep in mind.
Yeah.
Okay, what about PSVT? The patient's heart is suddenly racing at 180 beats a minute. They are feeling palpitations, chest pressure, and dyspnea.
For PSVT, our actions are ranked. First, assuming they are stable, we try vagal maneuvers. We ask the patient to bear down as if they're having a bowel movement, the Valsalva maneuver.
And that just stimulates the vagus nerve to naturally slow the AV node. Deep into adenosine, and honestly, the mechanism sounds terrifying. It's described as a hard reboot for the heart.
It absolutely is, and it can be terrifying for the patient. Adenosine briefly blocks conduction through the AV node entirely. When you push it, it effectively causes a brief period of complete asystole.
So they just flatline.
Yeah. The patient will flatline on the monitor for a few seconds before the SA node hopefully reasserts itself and takes over in a normal rhythm.
You are intentionally flatlining them. So the independent nursing action here has to be massive patient education. You have to warn them that they're going to feel a sudden, intense wave of chest pressure and a feeling of impending doom.
Yes, you must explain that it will feel terrible, but it will pass in seconds. And from a pharmacological standpoint, adenosine has a half-life of less than 10 seconds.
So you have to push it fast.
Extremely fast. If you push it slowly, the blood enzymes will chew it up before it ever reaches the heart.
So it's a rapid IV push, 1 to 2 seconds, ideally through a stopcock on a line as close to the heart as possible, followed instantly by a rapid 20-milliliter saline flush. Elevate the arm to get it central.
Exactly. But what if the adenosine fails? Or what if the PSVT patient is hemodynamically unstable from the start, like crashing blood pressure, altered mental status?
Then we don't mess around with meds. We go straight to synchronized cardioversion. We are delivering a shock to convert the rhythm.
But here is where we circle all the way back to the very beginning of our discussion. If you are doing a synchronized cardioversion, you must visually confirm that the sync button on the defibrillator is engaged. Why?
Oh, because if the sync button is on, The machine reads the patient's ECG and times the delivery of the electrical shock to fall precisely on the R wave of the QRS complex.
And if you forget to hit the sync button,
Then it's just a blind defibrillation shock. And if that blind shock randomly lands on the T wave, that's the R on T phenomenon, you'll send the patient straight from PSVT into lethal ventricular fibrillation.
Exactly. A simple missed button can kill your patient instantly. That is why understanding the underlying electrophysiology is critical.
So synthesizing this supraventricular section into the 5 things to remember. 1. Core patho is extreme atrial rates, destroying diastolic filling time in PSVT, or causing blood stasis in AFib.
Right.
2. Key assessment is an irregular rhythm for AFib, or an abrupt extreme tachycardia for PSVT. 3. Most dangerous complication is embolic stroke for AFib, or severe hypotension for PSVT.
Exactly.
4. Priority nursing action is to control the ventricular rate and assess for hemodynamic instability. And 5. Most important treatment is adenosine for PSVT, rate-controlling drugs, and anticoagulation for AFib.
Perfect. So the one-sentence clinical picture for PSVT. A patient experiencing palpitations and dyspnea with a regular heart rate of 180 beats per minute.
And the rule.
If you see a sudden, regular, narrow complex tachycardia at 180, think PSVT and do vagal maneuvers or push adenosine. And for AFib, if you see an irregular rhythm with no P waves, think AFib and prioritize rate control and stroke prevention.
That encapsulates the entire intensivist mindset we've been talking about. You aren't just reacting to alarms, you're evaluating the failing physiology at a cellular and mechanical level. You understand why losing atrial kick compromises perfusion, why a severed AV node makes atropine useless, and why a mistimed shock causes sudden death.
You are anticipating the bottlenecks in the grid before the lights go out.
It changes entirely how you look at the patient. But as we wrap up, there's a fascinating detail in the source material about the future of this grid management. We talked earlier about pacing patients with third-degree block and the eventual need for a permanent transvenous pacemaker. But those wires, those leads, come with massive complications.
They do, yeah. Transvenous leads run directly through the blood vessels into the heart. Over time, those wires can fracture, the insulation can break down, or they can become highways for severe systemic infections like endocarditis.
But the text mentions a future where we eliminate the wires completely. Leadless, battery-free pacemakers.
Yes, the engineering is incredible. We are looking at a future where a tiny receiver, like a seed, is placed directly into the cardiac chamber tissue. There are no batteries or wires inside the heart.
So how does it work?
An external transmitter beams ultrasound energy right through the patient's chest tissue. That little seed captures the acoustic energy and converts it into the electrical pacing pulse that stimulates the muscle.
Beaming sound waves to power a heart. That is just mind-blowing.
It raises some profound clinical questions for you to mull over. I mean, if we completely remove intravenous leads from the equation, how will that alter the landscape of ICU complications? How will it redefine cardiac resynchronization therapy for our most vulnerable, infection-prone heart failure patients?
It's an incredible thought experiment for the future of critical care. We want to challenge you to take this intensivist framework straight to the bedside on your next shift. Don't just follow the protocol. Keep questioning the why behind every intervention, every medication mechanism, and every subtle change in the vital trends.
Because anticipating the deterioration is exactly how you save a life.
So the next time you look up at that monitor, don't just see jagged white lines. Look for the flow of energy. Look for the failing physiology. Be the one who understands exactly how to keep the city's lights on when the grid starts to fail. Thanks for joining us on this deep dive.